Hello again, everybody, and welcome to case study number 15. This is going to be a young adult patient presenting with neck pain. If you haven't had the opportunity yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I really appreciate all the contributions I can get to help keep these videos free and coming and offset the cost. I thank everybody for their consideration, and also especially those of you who have already subscribed. All right, so we got a 20-year-old East Asian American woman coming into the ED complaining of neck pain and chills for the last 12 hours. She says that she commonly gets a stiff neck, but that this is quote-unquote different, and she usually does not have chills. She took her temperature at home and it was 102 degrees Fahrenheit, which prompted her to come into the ED. She endorses a headache, but she says she has them all the time when she doesn't have caffeine. Review of systems is otherwise unremarkable. She's unaware of any sick contact. She's a college student, denies alcohol, tobacco, recreational drug use. She is not sexually active. She has no significant past medical history, and she's on a multivitamin. Blood pressure 122/84, heart rate 110. Respiration's 14, temperature 102.2, and she's setting 100% on room air. What do we know about this patient? She's got fever and a headache. And not to mention, she's also got a neck ache. What does this mean? We are very worried about meningitis. That triad is very common with meningitis. Okay, so we're going to go on and do our physical exam on CCS. You should always do that next. So in general, she's ill-appearing. Her neck has mild pain deflection. HENT, no papilledema. Chest, lungs, heart are all normal. Abdomen is fine. Neuropsychiatric exam shows normal mental status, normal cranial nerve examination, and importantly, no focal neurologic signs. All right, what is our differential diagnosis here? Meningitis. Number one on our differential, far and away meningitis. There's a few different causes of meningitis. Bacterial, viral, and fungal are the most common. There are some less common causes, Rocky Mountain spotted fever, Lyme disease. Those are less likely. Meningoencephalitis, often just an extension of meningitis, but it is something to consider. Typically, this shows altered mental status, though. And then Lyme disease is another possibility. It causes encephalitis. All right, so what are we going to do for our lab workup? We're going to get a CBC and BMP routine labs, and importantly, we're going to get a CSF analysis, which is done via lumbar puncture. We're going to get cell count, glucose, protein, and gram stain of that. You should know that because you have to order those each individually. Blood cultures are something that needs to be done, and this is critical. You suspect meningitis, so as soon as you get those blood cultures, you're going to start empiric antibiotics and dexamethasone. Now, if for whatever reason in real life there's any reason for a delay in that blood culture, don't wait. Just get the antibiotics on board right away. Okay, you don't want to wait for that, but on CCS, you won't have to wait. All right, what do we see? CBC shows leukocytosis with left shift. BMP is fine. CSF, okay, this is where it becomes important. So large number of white blood cells, low glucose, high protein, and the gram stain is pending. Blood cultures are also pending, and our medications have been started. Okay. CSF findings. You probably remember this from step 1 and step 2, but you should be familiar with the CSF findings, how you can differentiate bacterial, viral, and fungal. Now, that being said, we started these antibiotics already. We don't wait for the LP, but you should be familiar with how you do this. Big one here, if you see a low glucose, it's probably bacterial. So our diagnosis is bacterial meningitis. The treatment is empiric antibiotics. And in this patient, it's going to be ceftriaxone and vancomycin along with dexamethasone. Now, some pointers here. Empiric antibiotic therapy is age dependent. So you need to know the different treatment regimens for neonates, small children, children and adults, and older adults, namely over 50. My mom would kill me if she knew I called her an older adult. Important to give dexamethasone to all patients except for neonates. You're going to admit this patient to the ICU, and as usual with patients admitted to the ICU, you've got a number of orders: fluids, pulse ox, blood pressure monitoring, cardiac monitoring, get a Foley in, and monitor eyes and nose. If the patient has meningococcal meningitis, which you would find out either by gram stain or by culture, you're going to report that to the health department. You'll also want to inform the patient that she should inform any close contacts that she had meningococcal meningitis so that they can come in for rifampin prophylaxis. Bacterial meningitis should always be suspected in patients with a fever and a neck or headache. Atypical symptoms tend to occur in infants and older adults, so watch out for that. Infants are not going to be able to talk to you, so it's very important that you recognize some of these abnormal symptoms, namely temperature instability. You can't always expect a fever in a baby. Sometimes they'll have hypothermia, irritability, lethargy, poor feeding, and so forth. In older adults, they may not have pain. They may not have a fever. Sometimes confusion and altered mental status may be the only presenting sign. Empiric antibiotics should be given as soon as cultures are obtained. Do not wait for the lumbar puncture or the CT. You're probably like, what are you talking about with the CT? You're going to get a CT before lumbar puncture in patients with risk factors for cerebral herniation. So that's going to be any patient with CNS signs, altered, seizure, focal deficits, and importantly, Cushing's triad. So those aren't necessarily neurologic signs, but if they've got a wide pulse pressure, bradycardia, strange respirations, consider that a possibility of cerebral herniation. Also, if they're immunosuppressed. So the CSF and bacterial meningitis, you expect a high cell count because there's bacteria and because there's white blood cells. High white count and a low glucose. Just way to remember that, bacteria eat sugar, so you're going to have a low glucose in the CSF. The causes and treatment of bacterial meningitis by age are different, but note the top two causes after age 1 are all the same: strep pneumo and Neisseria meningitidis. Now this will bounce around depending on the exact age, but that's important to know because your antibiotic management is pretty much always going to be ceftriaxone and vancomycin, with the exception of older adults where we'll add ampicillin. You know, it's commonly said that as you get older, you get younger. So I kind of tell my grandma, because she's always like, what are you having for breakfast? And she's having graham crackers and applesauce, kind of like a little kid. Well, it just so happens with older adults, the risk of listeria goes up, just like in newborns. So for that reason, we add ampicillin to their regimen, just like we do in newborns. In newborns, it's a little bit different. Instead of using ceftriaxone, we use cefotaxime. Ceftriaxone is typically not given to newborns. And of course, we have ampicillin. The only other difference with newborns, no steroids. So dexamethasone for everybody else, though. Some common differentials: viral and fungal meningitis. They have similar presenting features. Fungal tends to be slower onset, often they're immunocompromised, think AIDS, and you're going to differentiate both of these on CSF analysis. Meningoencephalitis tends to have meningeal signs with altered mental status, difficult to differentiate, very similar causes though. Lyme disease, slow onset. Look for history of outdoor activities. They don't come in December, they come in June or July, and they may have that target-like rash. This is an algorithm from the AAFP. You can print this out if you want. So to recap, suspect meningitis in patients with a fever, neck ache, and or headache. Antibiotic treatment takes priority over identifying the exact cause, including the CT and the LP. Get the cultures first. The first step is always antibiotics. Head CT before LP in patients with signs of cerebral herniation. CSF can help differentiate bacterial versus viral versus fungal, but not the exact cause. That is secondary to the antibiotic administration. Some pearls for treatment, except for in neonates, ceftriaxone and vancomycin are always part of therapy. In neonates, use cefotaxime instead of ceftriaxone and add ampicillin. And in older adults, add ampicillin. Dexamethasone for everybody except neonates, and if there is meningococcal meningitis, the patient should notify contacts and they get rifampin. A lot of times you can just prevent this by getting your meningococcal vaccine. It's recommended for anyone who's going to be in dorms, in prisons, in army barracks, and so forth. So that's important for you to be aware of.